The following podcast is part of a certified educational activity titled Early Diagnosis and Evolving Management of Eosinophilic Esophagitis in the Era of Targeted Therapy. Access the entire activity and complete the post-test at peerview.com/PUG860. Downloadable slides and practice aids are also available.
Hello, and welcome to this educational activity on early diagnosis and evolving management of eosinophilic esophagitis in the era of targeted therapy. My name is Mirna Shehadi. I'm a professor of pediatrics and medicine and the founding director at the Mount Sinai Center for Eosinophilic Disorders at the Icahn School of Medicine at Mount Sinai in New York City. And joining me is Dr. Evan Dellon, professor of medicine and adjunct professor of epidemiology, and director of the UNC Center for Esophageal Diseases and Swallowing in the Division of Gastroenterology and Hepatology at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. Our goals for today are threefold. Number one, improve your ability to recognize signs and symptoms of EOE in children and adults and use the latest criteria in collaboration with the healthcare team to achieve prompt and accurate diagnosis. Number two, expand your knowledge about the benefits and limitations associated with standard medical and dietary treatment approaches for EOE. Number three, provide you with strategies to integrate targeted biologic therapy appropriately using the latest clinical evidence and shared decision-making for patients with EOE. Let's start with overcoming barriers to diagnosis in EOE. The prevalence of EOE has been increasing over the past few decades. This increase is not only due to better awareness, recognition, and accurate diagnosis of EOE, but also due to an actual increase in incidence beyond what we can explain on better education and more frequent endoscopies over time. In fact, EOE is no longer considered a rare disease. Therefore, you are bound to encounter many patients with EOE in your practice. This brings us up to the epidemiology of EOE. In other words, who are the patients more likely to have EOE? The majority of patients with EOE are children, adolescents, and adults aged 50 years or younger, but EOE can affect all ages. EOE is reported to be twice as common in male patients than in female patients, and it has been more commonly reported among white patients. However, keep in mind that it can affect all sexes and all races. It's important to know the clinical presentation of EOE so that you do not miss the diagnosis. EOE symptoms and signs vary with age. Infants and children typically have non-specific gastrointestinal symptoms. These include gastroesophageal reflux-like symptoms, nausea, vomiting, and abdominal pain. In infants and toddlers, symptoms centered around feeding are common, and these include food refusal and feeding difficulties. Failure to thrive can be present in children with EOE and should be a red flag to prompt you to look for the diagnosis of EOE when faced with nonspecific symptoms. Adolescents and adults often have a more specific clinical presentation, that of esophageal symptoms. These include solid food dysphagia and at times esophageal food impactions. A subset of these patients can also have a nonspecific presentation mimicking that of acid-induced reflux disease, including substernal chest pain, heartburn, and regurgitation. These symptoms are typically not responsive to antacid therapy, however. If we plot the predominant symptoms by age in a graph, we see that younger children present with feeding difficulties. Vomiting and abdominal pain are most common in older children, while dysphagia and food impactions are most common in adolescents and adults. Please keep in mind that multiple symptoms can coexist in a patient with EOE and with variable frequency. For example, a child with EOE can have daily abdominal pain and intermittent vomiting. In addition, patients with EOE of all ages tend to have behavioral feeding modifications, which they develop in order to reduce the severity of their dysphagia and to prevent food impactions. These behaviors can be remembered using the acronym IMPACT. I is for imbibe fluids to facilitate passage of solid food. M is for modify foods, so they cut them into small pieces or they puree the foods. P is for prolonged meal times. A is for avoiding harder textured foods. C is for chewing excessively their foods. And T is for turning away pills and tablets. The last point is important when you prescribe medications to patients with EOE in the form of tablets and capsules to make sure that they are small in size to prevent the risk of esophageal pill impaction. In addition, patients' adaptive behaviors tend to mask their symptoms. Therefore, when inquiring about dysphagia in a patient, it's also important that you inquire about their feeding patterns as well in order to avoid diagnostic delay. Indeed, diagnostic delay is still unfortunately common for patients with EOE. Shaheen and colleagues found that the time between symptom onset of EOE and the diagnosis ranged from 1.2 to 3.5 years in children and 3 to 8 years in adults. In a multi-center study that we reported in 2018, which included 705 patients aged 6 months to 65 years, we found that this time gap increased as the patient age at diagnosis increased. The median time from symptom onset to diagnosis was 1 year in children less than 11 years of age, 2 years in patients 11 to 17 years of age, and 4 years in adults. Presence of food allergy and atopic dermatitis was associated with a more prompt diagnosis. These comorbidities were more common in the younger population. Timely diagnosis of EOE is important to prevent complications of untreated disease. These include esophageal stricture. Of patients with severe diagnostic delay of 2 decades or more, Warner's and colleagues found that 57% of their patients had esophageal food impactions and 52% had an esophageal stricture. Another complication is feeding dysfunction, especially relevant for children. Bukada and colleagues reported that 14 to 60% of pediatric patients with EOE have feeding dysfunction. 21% of children with EOE and feeding disorders also had failure to thrive. Thirdly, untreated EOE can have a negative impact on patients' quality of life. So how do we diagnose EOE? According to the most recent consensus recommendations, if you have a patient with a clinical presentation suggestive of EOE, then the next step is to undergo an upper endoscopy with biopsy. And if biopsies demonstrate esophageal eosinophilia, in other words, 15 or more eosinophils per high-power field in the most involved areas, then the next step is to evaluate for non-EOE disorders that cause or potentially contribute to esophageal eosinophilia. And if none are there, then the patient now has the diagnosis of eosinophilic esophagitis. On endoscopy, many features suggestive of EOE can be found. Examples include edema, white plaques or white exudates, and or longitudinal furrows in the picture shown to your left. And these are what we classify as the inflammatory features of EOE. In the picture to your right, we now see rings, which constitute one of the fibrostenotic features of EOE, the other one being an esophageal stricture. A good way to remember and note all possible endoscopic features of EOE is to use the EOE Endoscopic Reference Score, abbreviated as EREFS. Here, E stands for edema, R for rings, E for exudates or white plaques, F stands for furrows, and S for stricture. Each of those features can be graded, and then a total score is calculated, which provides with a measure of an endoscopic severity for your patient with EOE and allows you to track it following therapy. Histological diagnosis of EoE is relatively simple. A healthy esophagus is devoid of any eosinophils, as shown in the biopsy section to your left. A biopsy section from a patient with EoE, however, should have a pathologic number of eosinophils infiltrating the mucosa, as you could see in the picture to your right. In addition, other features can be present in that biopsy section, including eosinophil microabscesses, basal cell hyperplasia, and dilated intercellular spaces, among other features. Finding at least 15 eosinophils per high power field in the most inflamed area of the esophagus fulfills the histological criterion for the diagnosis of EoE. EoE is a patchy disease. Therefore, at least 3 biopsies from the distal and 3 biopsies from the proximal esophagus should be obtained. In addition, targeting endoscopic lesions, for example, white exudates, increases the diagnostic yield.
Thanks so much, Dr. Shahade. I am Evan Dellin, a professor of medicine and adjunct professor of epidemiology at the University of North Carolina School of Medicine, and also the director for our Center for Esophageal Diseases and Swallowing here. I will be talking about the standard medical and dietary approaches to managing eosinophilic esophagitis. To start with, I want to show you the new treatment algorithm in the forthcoming ACG EoE guidelines. And this has some changes from previous iterations of guidelines. And after the EoE guideline is established, the goal is to treat inflammation and assess for fibrous stenosis in all patients. And when we start with anti-inflammatory treatment, we make a decision about, is it pharmacologic treatment or is it dietary elimination treatment? And this is done in a shared decision-making model. Once that decision is made, you would go to a first-line treatment. And for pharmacologic therapies, this is also often PPIs and then topical steroids. And for diet elimination, it's empiric diet elimination. After you institute a therapy, you would assess response, not only assessing symptoms, but also assessing the endoscopic appearance and assessing biopsies and the histologic activity. And at the same time, you would make another fibrous stenosis assessment. And at this time, if there's a stricture or narrowing present, you can perform esophageal dilation to a goal diameter of about 16 to 18 millimeters. Of course, at the very first step, when you're also assessing for fibrous stenosis, if there's a stricture, it can be dilated at that time as well. After you assess the response, if there is a DICE response, patients would generally maintain on their therapy and undergo long-term monitoring because EoE is chronic. And if there's not response, then you could change or modify prior therapies or move to a biologic such as dupilumab, and then go back assessing response both to the inflammatory aspects of the disease and the fibrostenotic aspects of the disease. This algorithm is a little bit different in terms of the emphasis on assessing inflammation and fibrostenosis and treating them in parallel, and the careful assessment of response in multiple domains of EoE. Now let's move ahead and talk about some of the specific treatments. The first are proton pump inhibitors, and initially these were a way to distinguish EoE from GERD, but it turns out that there are anti-secretory and anti-inflammatory mechanisms where PPIs work in EoE, and in updated diagnostic guidelines, PPIs were removed as a diagnostic criterion and instead moved here into the therapeutic realm for EoE. Meta-analyses have shown a histologic response rate of about 42%, and because of the low cost, ease of administration and access, and a long-standing good safety profile, these often are a primary therapeutic option in many people and would be a first-line pharmacologic therapy. Now, if we think about dietary management, in prior guidelines, as well as the upcoming ACG guidelines, dietary elimination is recommended for EoE, and in general, empiric elimination diets are the ones that are recommended. And the thought when you're doing dietary elimination now is that EoE, we think in many people, is triggered by food antigens, and it's a food-driven process in many people. And so the goals of dietary therapy are to eliminate food allergens and try to get the disease into remission, and then if necessary, reintroduce foods in a sequential fashion to identify which of the food triggers may be causative, because up front you often may eliminate more, and you want to have people have the least restrictive diet as possible going forward. So these are effective and acceptable long-term treatments. They are really the only non-pharmacologic alternative and can also be used first line. Now, when you go to use these therapies, it's really important to partner with a dietitian or nutritionist to maximize adherence and success and to support the patient through this process. Now, in general, the options that we are talking about are empirical elimination diets, where you remove the foods that we think statistically are most likely to cause EOE. And then the other option really is the elemental formula, which is a hypoallergenic amino acid-based formula with very high remission rates, 90% or above. But this is really infrequently used because it's a liquid-only diet. Many times it may not be palatable. It's expensive, it's often not covered by insurance, and it's challenging for food reintroduction. So elemental is really reserved for infants and for patients with very severe refractory disease. And instead, we're really looking at empirical elimination. Now, the new guidelines suggest actually against the targeted elimination, where you would use standard allergy tests like skin prick tests or patch tests or blood tests to guide your diet, because those are not accurate for EOE. And so when we eliminate foods for EOE, we might do a 1, a 2, a 4 food, a 6 food elimination, etc. When you're doing an empirical elimination diet, then, well, what are the specific foods that you would eliminate? Well, for the traditional 6 food elimination diet, that gets rid of 6 groups. So that's dairy, wheat, egg, soy, nuts, which includes peanuts and tree nuts, and seafood, which includes both shellfish and finfish. Then you've got the 4 food elimination, which is dairy, wheat, egg, and soy. The 2 food elimination, which is dairy and wheat. And the 1 food elimination, which is just dairy elimination. And there's certain ways to do this. Traditionally, we've done the step down 6 food elimination diet, where you start eliminating all 6 of those food groups. You perform an endoscopy after about 6 weeks. If there's a response, you know 1 or more of the foods in that group are the triggers. And then you would sequentially add back a single food every 2, 4, or 6 weeks, depending on the logistics. Repeat a scope to see whether that food is flaring up the EOE and is a trigger. And if it is, you remove that food. That's a long-term trigger that's going to be removed forever. And then you would add back the next food and so on. This is a pretty time-intensive and resource-intensive process. And so some people instead opt for a step-up elimination diet, where you may remove a smaller number of foods like dairy and wheat, or a 2 food elimination, have a scope. If you have a response there, you're done. If you're not, then you move on to a more restrictive diet like the 4 foods, so dairy, wheat, egg, and soy, and then again, repeat the scope. And again, if it looks good, then you can start the reintroduction process. If it's not under remission, you can even go a step further and do the 6 food elimination at that time. So the real question is, which one of these diets might you start with? And part of it is based on patient preference, but meta-analyses have shown that the more restrictive you get, the higher the response rate. So perhaps response rates around 60% with 6 food, maybe 50-ish% with 4 food, and 40 to 50% with 1 food. But recently, there have been 2 randomized trials that I think really shed a lot of light on this topic. The first was a 1 food versus 6 food elimination diet in the group, the Consortium for Eosinophilic GI Disease Researchers, where they performed a multi-center study. And patients were randomized to the 1 or the 6 food elimination. And at the end of the day, the histologic response rates for looking at less than 15 EOs per high power field were very similar, 34% for the 1 food and 40% for the 6 food. So that gives data that perhaps in adults, starting with a 1 food like dairy only is a more feasible way to start, and gives a similar efficacy as the 6 food. Similarly, that same group did a 1 food versus 4 food elimination in the pediatric population. Again, a multi-center randomized trial. And again, it's the same information, where the response rates were very similar between the groups for histologic remission. Just a little bit above 40% for the 1 food, and a little bit and close to 40% for the 4 food. So again, I think these 2 trials combine and show some strong data that maybe starting with a less restrictive empirical elimination diet is the way to go. Now, going back onto the other side of the algorithm, where we're talking about medications, topical steroids are a recommended therapy for EOE. And the idea here is that you're coating the esophagus with a swallowed anti-inflammatory steroid. that broadly affects the pathogenesis of EOE. And for many years, we were adapting asthma medications to be swallowed into the esophagus. In 2018, an oral dissolvable budesonide tablet was approved in Europe. And finally, here in the US, we had the budesonide oral suspension approved in February of 2024 for patients 11 years and older for a 12-week course at 2 milligrams twice a day. Depending on what formulation you may choose, the histologic rates may vary, but generally they're in the 60 to 70% range, plus or minus a little bit. These are quite safe. The main adverse event is going to be esophageal candidiasis, and a prior randomized study showed similar efficacy to systemic corticosteroids, but with just a fraction of the side effects. So systemic corticosteroids are really not used for patients with EOE in routine practice. Now, when we focus in on the budesonide oral suspension data, these are the phase 3 data from a trial of patients age 11 to 55 who were randomized 2-to-1 to either get budesonide oral suspension or a matching placebo. The study had more than 300 patients enrolled. And when we're looking at a histologic response that's stringent at 6 or fewer EOs per high power field, it was highly significant, about 53.5% in the budesonide group compared to just 1% in placebo. That met one of the co-primary endpoints of the study. The other co-primary endpoint was symptom improvement with symptoms of dysphagia using a metric called the Dysphagia Symptom Questionnaire. And here you saw significantly more people with at least a 30% reduction in dysphagia with budesonide than in the placebo group. And so these are the data on which the approval was largely made. After you've chosen your initial therapy, whether it be a PPI, a topical steroid, or diet elimination, the next thing to do is to assess treatment activity and try to treat to target in this condition. And so that involves looking at 3 different domains of disease activity and assessing them all. The first is symptoms. How is the treatment making the patients feel? And this is an important domain because, of course, we want patients to feel better, but it's not adequate to simply monitor symptoms. You also need to look at the biologic activity of the condition because symptoms often do not correlate with histologic or endoscopic activities. So in addition to assessing symptoms, you want to perform an endoscopy, assess the endoscopic severity and improvements in any of the endoscopic features, assess whether there is a stricture that needs dilation, particularly if there's ongoing symptoms, and are you getting to that goal of 16, 18 millimeters to dilate? That endoscopy also lets you do biopsies, so you can assess the histologic activity, aiming generally in clinical practice for at least a eosinophil count of less than 15 EOs per high power field, and it can let you assess other histologic elements as well. Interpreting these 3 domains together allows you to get a sense of whether your patient is having a complete response, whether there's complete non-response, or whether there are individual domains where you have to work more on and target the therapy a little bit better or consider alternate therapies. So with that discussion of the first-line therapies in EOE, please stay tuned to hear more about EOE treatment. This segment will discuss practical considerations for the integration of targeted therapy into treatment plans for patients with EOE. To start with, it's important to understand that there's multiple factors that contribute to EOE pathogenesis and etiology. There is the general cellular pathway, the type 2 inflammatory pathway, which leads to patients with EOE often having high levels of concomitant atopic disease. There are certain genetic predispositions of EOE that may help to trigger the disease. In some families, it can run in the family. There are environmental risk factors for EOE and also demographic type risk factors as well. For the pathophysiology, EOE is a type 2 inflammatory condition that ultimately is diagnosed when we see infiltration of eosinophils into the esophagus. However, it's important to realize there's a lot more going on in the pathogenesis than just EOE, and our current model suggests that there may be a defect or a barrier in the esophageal epithelium which interacts with environmental allergens, possibly microbiome, that starts a typical T2 inflammatory process, starting with alarmins that then activate T cells that then pump out a bunch of very typical cytokines like IL-4, IL-5, and IL-13 that are associated with allergic disease. And ultimately, through a series of other mediators, lead to what we see clinically for EoE, which is eosinophilic inflammation, ongoing loss of barrier function, and esophageal remodeling. But in addition to eosinophils, mast cells and other inflammatory cells are often also involved in the pathogenesis and can be picked up on the biopsies with special staining. In terms of atopy, the majority, and sometimes the large majority of patients with EoE will have other atopic conditions such as allergic rhinitis, asthma, atopic dermatitis, and food allergy. And in one study, nearly 80% of EoE patients were reported to have at least one atopic condition, and nearly half had more than one, with 22% having at least three. So your EoE patients often have atopic conditions, and this is one reason to collaborate closely with the allergist to make sure these other atopic conditions are under good control. Now, when we think about targeted therapies for EoE that may target certain aspects of the pathogenesis, these are often biologic medications. And why would we consider these for EoE? Well, if patients are refractory to other treatments, so they don't respond to topical steroids, or if they've had side effects or lose response to topical steroids, you could consider this. There's a theoretic concept that it's nice to target the underlying allergic pathways. Some medications may allow systemic treatment of multiple forms of atopy with one treatment rather than multiple treatments for individual conditions. And sometimes biologics may be dosed less frequently than daily or twice daily therapy that the other PPIs and topical steroids. So when we think about where we place the treatment algorithm and where we may place a biologic in the treatment algorithm for EoE, these are generally considered step-up medications. So what that means is that for most patients, you're going to use a biologic medication, for example, dupilumab, which is approved for EoE, after PPIs and topical steroids have not been effective. Now, there are some cases where the medication can be used a little bit earlier, and we will talk about those. But in general, you can see in this updated algorithm from the new ACG guidelines that dupilumab is positioned for most people after trial and failure of first-line therapies. So dupilumab is the first biologic that was approved for EoE, and it's an antibody against IL-4 and IL-13, those two key cytokines that we discussed in the pathogenesis of EoE. It was approved based on a phase 3 trial, placebo-controlled, multi-center randomized trial with treatments up to 52 weeks. Primary outcomes were assessed at 24 weeks with longer-term therapy. And essentially, it showed that weekly dupilumab injections was associated with improvements in both histology and symptoms in adults and adolescents with EoE. So about 60% of those treated with dupilumab achieved histologic remission at 24 weeks compared to just 6% in the placebo group. And those patients also experienced a greater reduction in dysphagia symptoms compared to the placebo group. These treatment effects were maintained up to 52 weeks with, in many cases, some improvements. In addition, dupilumab led to improvements in the endoscopic appearance of the esophagus as well in EoE patients compared with placebo, where it really didn't change. In general, it was well tolerated. The common adverse events included injection site reactions such as erythema, pain, and swelling, and nasopharyngitis. Now, one point about this is for EoE, the dosing is weekly, and that's different than the dosing for the other atopic conditions such as asthma and eczema, where the dosing is every other week. So you need to pay attention to that if you're going to use that. In a follow-up study called the KIDS study, this focused on children aged 1 to 11 years old to look at the efficacy in that younger patient population. And the data from that study led to, in early 2024, the medication being approved for kids down to 1 year of age, where previously it was 12 years and above. And so this study was also a multi-center randomized trial. Here it assessed primary outcomes at week 16 and followed the patients through to week 52. And similar to the study in the older patients, It saw a marked improvement in histologic response with the higher exposure dupilumab compared to placebo. It also showed improvement in endoscopic features and improvement in body weight for age percentile. So there was also an improved growth with dupilumab compared to placebo. And again, these effects were maintained out to week 52. Again, no new treatment signals in this study. And actually, there were more adverse events leading to study drug discontinuation in the placebo group than with dupilumab. So now this medication, again, is FDA approved for those aged 1 and above. You should know that the dosing is different based on weight. So the dosing for children 15 kilos to up to 30 is going to be 200 milligrams every other week. The dosing for people 30 to 40 kilos is 300 milligrams every other week. And then the dosing for 40 kilos and above is 300 milligrams weekly. So that is also something to pay attention to. And for pediatric providers, as your kids are growing, you may need to alter that dose. Now, with that clinical trial data out and the medication approved, we're starting to get data on real-world efficacy for dupilumab. And one group of patients that were not included in this study were those with very severe fibrous stenotic EoE. So this is a study that was a retrospective cohort of 46 adults who had previously refractory EoE, severe fibrous stenosis, required frequent dilations, and because of that, couldn't be enrolled in the registration trials. And this showed that in general, when after treatment with dupilumab, they had relatively similar endoscopic, histologic, and symptomatic improvements as was seen in the clinical trials. So there was about a 57% histologic response rate with that stringent 6 or fewer EOs per high power field, 80% histologic response at the 15 EOs level, an improvement in the EoE endoscopic reference score from 5 out of 9 to 1.9 out of 9, and also a global symptom improvement reported by all patients. But remember, this was an uncontrolled study. Patients were also being dilated at the same time. But their strictures were able to be dilated to larger sizes with the use of dupilumab. So some initial data that perhaps it can be used in the most severe of the EoE patients. In addition to the recent ACG guidelines, there are some other guidelines and recommendations for use of dupilumab in EoE. And again, most of the considerations are for use as step-up therapy. So patients with difficult to treat EoE, who have been refractory to therapies or having adverse events to therapies, and also patients with a severe picture, such as failure to thrive, poor growth, weight loss, use of rescue therapies, or severe diet restrictions, or even those very severe esophageal strictures. However, there are some situations where you may want to consider earlier dupilumab, and this is where a patient has multiple comorbid atopic conditions where one medication, like dupilumab, that's also approved for asthma, atopic dermatitis, and chronic rhinosinusitis with nasal polyposis, if they have those conditions and EoE, you may be able to make their treatment way more efficient for them. And the only caveat there is you need to use the EoE dosing for the medicine. Be sure you're doing that. And then, of course, there are patients who would have a strong preference to avoid diet therapy or swallow topical steroids. All of the data we have in dupilumab so far are in PPI non-responders. So I think really patients should be tried with PPIs before they try dupilumab. How do we think about following up patients on biologic therapy? Well, just like with first-line therapy, after generally about 24 weeks, patients would need another upper endoscopy. So you assess their symptom improvement, their endoscopic features, and their histology. Throughout the studies, you can see symptoms improve as soon as 4 weeks after dupilumab therapy. But in general, because the phase 3 trial assessed outcomes at 20 weeks at 24 weeks, for many people, that's where you want to do your follow-up endoscopy to do your assessment of treatment response. Now, that has to be individualized. A very severe patient who requires frequent dilation may need an endoscopy sooner than that. But many patients can have that scope at 6 months. Now, in terms of other monitoring, in contrast to what we do for some of our IBD patients, right now we are not doing therapeutic drug monitoring with dupilumab. Antigenicity is very minimal, and so far that hasn't been necessary in asthma or eczema, where there's a much longer experience with using this medication than there is in EoE. Now, in addition to dupilumab, there are a number of other agents that are on the horizon for therapies. And it's, I think, an exciting time because there are a lot of things that are out there. One option, one new medicine under study is cendakimab. This is an antibody against IL-13, again, against one of those type 2 cytokines. And it inhibits signaling through both subtypes of the IL-13 receptor. This is also a weekly subcutaneous injection. Proof of principle was demonstrated in a randomized double-blind placebo-controlled phase 2 trial in 99 patients. This was in adults 18 and above, and 2 different doses were compared to placebo. And for both of those doses, there was a very strong decrease in the mean esophageal eosinophil count, which was the primary outcome. And they also saw improvements in histologic response and in the endoscopic appearance. And there was a strong trend towards symptom improvement. There is an ongoing phase 3 study, and results will be forthcoming. There has been an announcement that the study has met both co-primary outcomes. And so we are awaiting those data and whether this joins can be joined into the treatment algorithm for EOE. In addition to cendakimab, there are a number of other emerging targeted agents for EOE. In phase 3 testing is tezepelumab, an antibody against TSLP, one of the alarmins very high up in the pathway. There's barzolvolimab, which is in a phase 2 study. This is a mast cell depleting medication. Etrasimod and RL-1104 have both completed proof of principle phase 2 studies that show potential efficacy at EOE. And then there are a number of other agents targeting cytokines like an anti-IL-15 antibody or other small molecules such as a JAK inhibitor that theoretically could be used in EOE. I will make a note that some of the antibodies that are eosinophil depleting, like benralizumab, larentilimab, and mepolizumab, have been tested in EOE. And even though they're very good at getting rid of eosinophils, they don't seem to improve the other clinical and endoscopic features of the disease, so aren't being pursued right now for EOE treatment.
Now we will move to beyond the esophagus, potential clinical implications of targeted therapy in the treatment of eosinophilic gastrointestinal diseases. Before we get into therapies, let's start with some definitions. Eosinophilic gastrointestinal diseases, or EGIDs, are a heterogeneous group of chronic inflammatory disorders characterized by eosinophilic infiltration of the gastrointestinal tract from esophagus to the rectum in the absence of secondary causes of eosinophilia or systemic disease. They are typically divided into EOE and non-EOE EGIDs. Clinical presentation varies based on the affected section of the GI tract involved and the depth of eosinophilic infiltration through the layers of the GI tract. Therefore, patients with non-EOE EGIDs can have mucosal, muscular, and/or serosal forms of their disease. In the past, the term eosinophilic gastroenteritis was often used to refer to non-EOE EGIDs. It was vague, and you couldn't tell if it was referring to one or more segments of the GI tract. In 2022, a new nomenclature for non-EOE EGIDs was born out of a large international consensus effort, which helped identify these diseases with more granularity. The new nomenclature can be summarized as follows. If a patient has pathologic eosinophilic infiltration of the stomach alone, they're labeled as having eosinophilic gastritis, or EOG. If the eosinophilic infiltration is in the intestine, these patients have eosinophilic enteritis, or EON, which can be further specified, if known, into eosinophilic duodenitis, or EOD, eosinophilic jejunitis, or EOJ, or eosinophilic ileitis, or EOI. Finally, if the eosinophilic inflammation is in the colon, then you are dealing with eosinophilic colitis, or EOC. Note that one or more segment of the GI tract can be concurrently involved in a patient with non-EOE EGID. For example, a patient can have eosinophilic gastritis and eosinophilic duodenitis. Non-EOE EGIDs are less prevalent than EOE. A recent systematic review and meta-analysis found 1.9% prevalence of non-EOE EGIDs in adults with GI symptoms. In a population-based US study, the prevalence of eosinophilic gastritis and/or eosinophilic duodenitis was 5.3 per 100,000 in children and 5.1 per 100,000 in adults. As for eosinophilic colitis, or EOC, the prevalence was found to be 1.6 per 100,000 in children and 2.3 per 100,000 in adults. By comparison, the prevalence of EOE is around 0.5 per 1,000, which is the equivalent of 50 per 100,000 individuals. This would mean that for every 10 patients with EOE, there's around 1 with non-EOE EGIDs. The current prevalence of non-EOE EGIDs is, however, most likely an underestimate, as diagnostic delay is common in these patients. In a large population-based study, we found significant delay in diagnosing these patients with EOG and/or EOD, and that's eosinophilic gastritis and/or duodenitis. In adults, this delay was up to 4 years. In children and adolescents, it was up to 3 years, and the delay occurred at every step of the patient journey, from clinical presentation to being evaluated by a gastroenterologist, and then from this evaluation to an endoscopy, and then from the endoscopy to the actual diagnosis. In fact, in many patients, more than one endoscopy with biopsies was needed before making the diagnosis. To put all of this into perspective, we identified and/or suspected several points of delay or attrition in diagnosing eosinophilic gastritis and/or eosinophilic duodenitis. Following symptom presentation, patients faced either a delayed referral to the gastroenterologist or a lack of a thorough workup, or received an alternate diagnosis with a non-specific GI condition, such as irritable bowel syndrome. Then after they finally had an upper endoscopy, many did not have biopsies obtained. Following a histologic evaluation of their biopsies for those who got biopsies done, they either did not have quantification of eosinophils on their biopsies, or the number and location of the biopsies were insufficient due to the patchy nature of eosinophilic infiltration in non-EOE EGIDs. It is important that you are aware of these findings so that you can learn from them and avoid these causes of diagnostic delay in your patients. This is because ongoing disease can cause a substantial burden on patients with non-EOE EGIDs. In a recent multicenter study of 715 patients with an EGID diagnosis, around a fifth of whom had non-EOE EGIDs, a higher proportion of those with a non-EOE EGID reported more frequent specific and non-specific GI symptoms, including nausea, abdominal pain, diarrhea, constipation, and bloating. In addition, patients with a non-EOE EGID were more likely to report higher frequency of fatigue, isolation, and deep muscle or joint pain. Gastrointestinal symptoms in patients with non-EOE EGIDs are typically nonspecific and multiple. Common symptoms include abdominal pain, nausea, vomiting, and/or diarrhea. In addition, patients can have bloating, loss of appetite, early satiety, and weight loss. Failure to thrive can occur in children with non-EOE EGIDs. As for bleeding, if it's coming from the upper GI tract, such as an ulcer on the stomach or duodenum in patients with eosinophilic gastritis or duodenitis, patients can have occult bleeding or melena in severe cases. If the bleeding is coming from colonic ulcers, as in the cases in a patient with eosinophilic colitis, you will see frank hematochezia. Patients with muscular involvement of the disease will show up with obstructive symptoms, and those with serosal involvement typically present with ascites. There are no standardized diagnostic guidelines for non-EOE EGIDs yet. There's general agreement, however, that diagnosis of non-EOE EGIDs requires recurrent GI symptoms, eosinophilia of the GI tract, as demonstrated by increased eosinophils per hand power field in biopsy specimens, and the absence of known secondary causes of GI eosinophilia. So what do we see on endoscopy? Findings vary depending on the area involved and the depth of disease in the GI tract. For mucosal disease of the stomach or small intestine, you may see ulcers, erosions, edema, erythema, friability, or granularity of the mucosa. You may even see thickened folds or nodules, and many of the patients can have one or more of these features. For eosinophilic colitis, endoscopic features include hyperemia, edema, friability, erosions, ulcers, nodules, and/or pseudopolyps. A scoring system for endoscopic abnormalities, e.g. RAFs, was developed for eosinophilic gastritis, akin to the ERAF score for EOE, although it has not yet been validated. It's important for you to note that a small subset of patients with non-EOE EGIDs can have a normal-appearing mucosa, hence the importance of obtaining biopsies regardless of the endoscopic findings if you are suspecting non-EOE EGIDs. Non-EOE EGIDs tend to be patchy in nature. Therefore, multiple biopsies are needed for accurate diagnosis. In a recent analysis of patients with eosinophilic gastritis and/or duodenitis with moderate to severe GI symptoms, we found that at least 8 gastric biopsies and 4 duodenal biopsies are required to identify these patients. For eosinophilic colitis, several areas of the colon will need to be biopsied and labeled separately. These include terminal ileum in at least 3 sites, cecum and ascending colon, transverse and descending colon, and the rectosigmoid area. Diagnostic guidelines were recently published for children with non-EOE EGIDs, where threshold peak eosinophil counts for the diagnosis of non-EOE EGIDs in children were suggested, as listed in the table to your right. Threshold numbers are not yet established for adults with non-EOE EGIDs. Blood tests are important adjunct diagnostic tools for patients with non-EOE EGIDs. These include the following: CBC with differential to determine hemoglobin, as anemia can be present in these patients. In addition, peripheral eosinophil counts can be elevated. Some patients with non-EOE EGIDs can have associated protein-losing enteropathy with the resultant low serum protein and low albumin. They can be losing blood from ulcers or can have malnutrition, and this can cause iron deficiency anemia. Therefore, iron panel and ferritin are important to measure in these patients. In addition, markers of inflammation, including C-reactive protein and ESR, are important to differentiate non-EOE EGIDs from inflammatory bowel disease. Stool tests are also important. They can be positive for occult blood in patients with bleeding ulcers. In addition, patients with associated protein-losing enteropathy can lose blood and protein into their stools. Therefore, they would have occult blood in their stool, as well as elevated alpha-1 antitrypsin levels. Of course, stool tests for ova and parasite and serology for strongyloides and Toxocara species are important to differentiate non-EOE EGIDs from parasitic infections that can also cause gastrointestinal eosinophilia. Once you diagnose a patient with non-EOE EGID, treatment is currently challenging, as there are no FDA-approved therapies to date. Per the recent guidelines on pediatric patients with non-EOE EGIDs, oral systemic steroids received a strong recommendation. Topical corticosteroids and empiric elimination diets received weak recommendation. PPI therapy was reserved for treatment for upper GI ulcers and received weak recommendation. Recent evidence, however, has been pointing towards an allergic immunopathology for some non-EoE EGIDs, namely eosinophilic gastritis and duodenitis, with a potential role for food allergens triggering these diseases, similar to what we have seen in many patients with EoE. This is exemplified by a recent prospective study of 15 adults with eosinophilic gastritis and/or duodenitis who were treated with an elemental diet consisting of exclusive feeding with a non-allergenic amino acid-based formula. Following 6 weeks of this diet, patients' eosinophils significantly dropped to less than 30 eosinophils per high power field in both the stomach and duodenum. This study supported a potential role for diet in treating patients with eosinophilic gastritis or duodenitis. As for targeted therapy for non-EoE EGIDs, anti-eosinophilic agents have not proven successful. Lirentelimab is an antibody to Siglec-8, which is present on the surface of eosinophils. Therefore, lirentelimab eliminates eosinophils via antibody-dependent cell-mediated cytotoxicity. It was tested in adults with eosinophilic gastritis plus or minus duodenitis. Although phase 2 results were promising, in phase 3 study, the histologic co-primary endpoint was met, but not the symptomatic co-primary endpoint. Therefore, this antibody was abandoned as a potential treatment for non-EoE EGIDs. Similarly, benralizumab is an antibody that targets the IL-5 receptor alpha, which is present on the surface of eosinophils. Therefore, benralizumab eliminates eosinophils via antibody-dependent cell-mediated cytotoxicity. It was tested in adolescents and adults with eosinophilic gastritis. Results of a phase 2 study showed that although histologic remission was induced, as defined by absence of tissue eosinophilia, other histologic and endoscopic features of the disease persisted, suggesting a coexisting eosinophil-independent pathogenic mechanism and the need for a broader targeting of type 2 allergic immunity. This brings us to dupilumab, which is currently seen as an emerging targeted therapy for non-EoE EGIDs. Dupilumab is an antibody against the IL-4 receptor alpha, which disrupts IL-4 and IL-13, two key type 2 allergic cytokines. Its efficacy has been reported in 2 retrospective case series, one that included 12 adults who received dupilumab, 2 with eosinophilic gastritis and duodenitis, 3 with eosinophilic gastritis, and 7 with eosinophilic duodenitis. All patients experienced improvement of at least one symptom with dupilumab. 3 had no change in severity and of 1 or more symptoms. 2 patients with eosinophilic gastritis and 3 with eosinophilic duodenitis were asymptomatic. 8 patients had repeat endoscopies with biopsies, and most achieved histological remission. The other retrospective case series included 3 pediatric patients who received dupilumab, all with multi-segment disease. 2 patients failed to achieve remission on standard of care therapies, and one patient experienced significant side effects on swallowed budesonide. On dupilumab, all achieved clinical and histological remission. In addition, there are currently 2 ongoing multi-center randomized double-blind placebo-controlled trials testing the efficacy and safety of dupilumab in adolescents and adults with eosinophilic gastritis, results of which in the near future will shed some more light on the potential for this targeted therapy for patients with non-EoE EGIDs. In summary, EoE continues to increase in incidence and prevalence worldwide. EoE diagnostic criteria have been updated. The diagnosis of EoE no longer includes a PPI trial. The diagnosis now is made based on appropriate symptoms in the setting of esophageal eosinophilia, as defined by finding 50 or more eosinophils per high power field, without another contributing cause for the esophageal eosinophilia. Symptoms and eating behaviors are often different in children and adults. EoE is a progressive disease from inflammation to fibrosis in most, but not all patients. Therefore, early diagnosis and ongoing therapy likely reduce complications. Targeted biologic therapy with dupilumab is now available for patients 1 year of age and older with EoE, and others are currently in development. Non-EoE EGIDs also carry a significant burden, and targeted therapy, including dupilumab, is also in development for this indication. On behalf of Dr. Dillon and myself, thank you for listening. We hope that this activity was helpful for your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/PUG860.